This video is going to focus on the use of token economies in the management of schizophrenia. And I'd just like to really just pause and emphasize that unlike CBT and family therapy, which are used in the treatment of schizophrenia, token economies are simply used in the management of schizophrenia. So they're not a treatment, they're not a therapy, they're certainly not a cure. This is just a technique that can be used to help cope with or manage the symptoms of the disorder. So token economies, they are a type of behaviorist therapy. This means that they are based on the principles of behaviorism. The most fundamental principle or assumption being that all behavior is learned. So therefore, we can unlearn behaviors as well. These were extensively used in the 1950s and 60s when hospitalization was the main method for dealing with schizophrenia, of course before the introduction of antipsychotics. Nowadays, we don't really use them, partly due to the closure of psychiatric hospitals, but also because of some really complex ethical issues that arise when you start to restrict rewards to people with severe mental disorders. So we'll discuss that when we look at evaluating the use of token economies. So in the UK, certainly, token economies are not really used in institutions anymore, but that's not true in some parts of the world. They do still use token economies in institutionalized settings in psychiatric hospitals. So in terms of the rationale, the reasoning behind the use of token economies, is that institutionalization, i.e. long-term life in an institution like a psychiatric hospital, can lead people to develop some really bad habits. Things like, for example, poor hygiene, lack of socializing with others, that sort of thing. And that's unsurprising and understandable when you consider that living without a routine or small pleasures for a long period of time is significantly going to affect your quality of life. So what we see quite often is that institutionalization, and here we're talking specifically about psychiatric institutionalization rather than, for example, in forensic psychology where we look at custodial sentencing. Here we're dealing with psychiatric institutionalization. So behaviorist therapies, they are based on the principles of operant conditioning, which means that the likelihood of a behavior recurring or repeating is based on the consequences that follow that behavior. And so remember that behaviorism is all about learning via association. And in this case, we learn whether to repeat a behavior or not based on the consequence that follows it. And by consequence, I know that word has negative connotations, but in behaviorism, we're talking really about reinforcement or punishment. If we receive reinforcement following behavior, we're more likely to repeat it. If we receive punishment following behavior, we're less likely to repeat it. And so here we're using behaviorist principles, and in particular, what we're really concerned with the token economy is the use of rewards and the use of reinforcement. And that can be used to help sort of manage the behavior of patients who have spent a significant time in psychiatric institutions, who might develop some patterns of maladaptive behavior. Things around personal care, perhaps avolition, interpersonal social behavior, typically negative symptoms we're seeing in institutionalized patients. So token economies can be or were somewhat effective at helping to establish more adaptive patterns of behavior. It's not a cure, it's not a treatment, it's just simply management of the symptoms. Then there are two really main benefits, I guess, for using token economies in an institutionalized setting. The first is that it improves the quality of life of those patients. So for example, for a patient who enjoys makeup and self-styling, who takes pride in their appearance, being able to improve their behaviors and get a nice reward, that's going to improve their quality of life. But the second thing it does is also help to normalize behavior. So it can help to sort of, I guess, retrain behaviors in people who have spent a long time in an institution to help them prepare for normal life in the community. Things like being able to get dressed, make their bed, and so on. Another unintended or perhaps intended consequence or side effect of this is that it helps the institutions themselves, it helps the clinicians, the nurses, the staff in the hospitals to help care for the patients as well. So there are lots of benefits to the use of token economies. So let's have a look at how they actually work. So this is what's involved. The first step is to identify specific target behaviours. And this might be done on an individual basis. So this is going to depend on what behaviours you'd like to see encouraged, what behaviours that person currently isn't engaging in. And from there, you'll develop a list of specific target behaviours. Then we start using tokens. Now remember that these act as secondary reinforcers. They don't themselves hold any value. They are meaningless. They are just a secondary reinforcer. Their meaning, their reward, comes from their ability to be swapped for a primary reinforcer. And this is something that is inherently, without needing to learn through reinforcement, something that is inherently rewarding. So that could be receiving makeup, having the choice of what film is watched, that sort of thing could be the reward for that patient. It's really important that those tokens are administered immediately following the target behaviour. If we're trying to learn via association between the behaviour and the consequence that follows it, that needs to appear very close in time to the behaviour. If there's too long a gap between behaviour and the consequence, the reward, the token, then that association, it will fail to form. If we think about training a dog, if they perform the target behaviour, and then 10 minutes later, once we've gone to the shops and we've bought a treat, we then give that dog a reward, they're not going to be able to make the association between the behaviour, the sitting, and the reward, the treat. And behaviourists think that humans learn in exactly the same way as animals. And so if that's how a dog learns, then that's how a human would learn as well. And we can extrapolate that then to patients in a psychiatric setting, that there needs to be a close sort of temporal link, time link, between the consequence and the behaviour in order for that association to form. So that's it. Simple as that. We now move on to look at evaluation of token economies. The AO3 is a little bit light, I've got to be honest. I think because we haven't used token economies in this country for some time, it's very, very hard to look at evidence for it. So I'd like you to really think about your knowledge of operant conditioning here. I'd like you to think about your knowledge of social sensitivity and ethics and bring all of that to the discussion in your AO3. So we're going to be looking at some research support. I'm going to put research in inverted commas there. You'll see why in just a moment. We'll talk about token economies perhaps only having a short-term benefit. The long-term benefit is unknown and is questionable. And then we'll have a look at the social sensitivity and the ethical implications associated with using token economies in an institutionalized setting. So let's start with some research support, research inverted commas. Now, these are not systematic studies. These are not randomized controlled trials where we've allocated patients to a token economy group or a no token economy group. In fact, this study, inverted commas study, is evidence from a book that was based on anecdotes and case studies. Not a rigorous case study, but really the observations of the researchers. So this isn't really research support. This is anecdotal evidence at best. But nevertheless, in this study, Elon and Azrin, they found token economies were a successful technique when used with female schizophrenic patients who are hospitalized for a really long time, 16 years. The key finding or the key report in that book is that the average number of daily tasks rose from 5 to 42. So those daily tasks were varied. Obviously, it was dependent on the individual, but could be things like making the bed, engaging in art therapy, taking medication without question, and so on. So this could be used to illustrate the success of token economies by getting patients to take more responsibility for themselves. So we're trying to encourage autonomy there. We're trying to encourage reintegration into the community after institutionalization. And so this can help people to become more independent, be more active rather than passive receivers of care, and so they can take charge of their illness a little bit better. This is very low quality evidence. Clearly this isn't a randomized controlled trial. Clearly this isn't a systematic review. This is just an anecdote from a book. So take it all with a little bit of a pinch of salt. I think in the age of evidence-based medicine, relying on an anecdote from a book, quite frankly, isn't really sufficient for experimental evidence. Nevertheless, there are other studies. Look at the dates of these. Oh my goodness, such a long time ago. This is a little bit more precise. This is looking at the use of token economies to help manage the side effects of antipsychotic medication. One major side effect that we know of that affects a large number of patients is weight gain. And so if we can use a token economy to help minimize the weight gain to keep them healthier, then that's going to have long-term benefits. And they found when using a token economy in this study that chronic schizophrenics achieved 3 pounds of weight loss a week using a token economy. So that would be receiving a token, a reward for selecting healthy options, for exercising, etc. So it seems like what we could infer from this is that when used alongside drugs that cause weight gain, they could be helpful at minimizing some of the side effects of those drugs. So it could be useful when used alongside the drugs to negate those negative side effects. As I say, research support in inverted commas there. The research is based on case studies. There are no RCTs where we've randomly allocated to the token economy group and the control to see which one has better outcomes. So it's not quite good enough. Further issues with the use of token economies is that we really don't have a good idea of the long-term benefits of the use of token economies. Most token economies are likely to only really provide a short-term benefit. And certainly only a benefit when used alongside other treatments like CBT or family therapy or social skills training. So although some evidence actually does find it's useful for improving maladaptive behaviors and dealing with some side effects of antipsychotic medication, it's really difficult, if not impossible, to know whether the behavioral changes persist beyond the token economy program. No fundamental research, no systematic evidence exists on the long-term benefits of token economies. The evidence that does exist has shown that there's low transference to the community, which means that despite there perhaps being an improvement in maladaptive behaviors in the institution, while institutionalized, once released from the institution, once taken into community care, those behaviors regress, that they don't then carry on performing those adaptive behaviors. And it's really, really hard, isn't it? Because in a community setting, outpatients are only really receiving treatment for a few hours a day. So there's going to be very minimal opportunity for them to display and be rewarded for their target behaviors. And without the rewards, we see the behavior being extinguished, as is the principles of operant conditioning. So while token economies may have a small effect on negative symptoms and reducing the side effects of antipsychotics like weight gain, we actually don't really know, and we suspect that they wouldn't really have any long-term benefits once that person is now being cared for in the community. I think the more interesting discussion around the use of token economies is around the ethical use of token economies. And we need to consider specifically here the population where we're trying to implement these token economies. We're dealing with very vulnerable patients. We're dealing with vulnerable patients who are in institutions, a vulnerable setting, and who already are being restricted from many of life's pleasures. The deal with token economies is that we only provide them with these rewards, these pleasures, when they perform the target behavior. And that, to some, is a little bit controversial. What it means is that those with milder symptoms, those who have less severe schizophrenia, are more likely to achieve the rewards. They're more likely to be able to perform target behaviors, so they're going to have more of life's pleasures. Which means that those who have more severe schizophrenia might not be able to perform the desired behaviors and therefore might not be able to get any tokens. So what we're happy with then is that we're restricting the availability of these pleasures to those who are already suffering the most severe illness. So those who are the most severely ill are making a bad time even worse, and this can result in lots of discrimination and humiliation. And actually what they found, one of the major reasons why they stopped using these, is that It was a way for the nurses and for the staff in institutionalizations to be able to control the patients. It wasn't for the patient's benefit. It wasn't to allow them to, learn new habits and overcome maladaptive behaviors. It was really a method of control. It gives them considerable power over the patients. So, for example, it could be seen as really dehumanizing. For somebody, for example, who has a nicotine addiction, which we see quite often, there's comorbid substance abuse associated with schizophrenia. So somebody who has a nicotine addiction now has to jump through hoops to be able to get cigarettes to satisfy that addiction. That doesn't seem like a very humanistic or a very ethical way of treating patients. Likewise, it sort of takes away their right to make choices. What if, for example, a patient likes to stay up late and likes to dress a particular way, but we only reward them for going to bed early and for not looking scruffy? That seems to now take away some of their autonomy and some personal freedom. And it means that maybe any benefits of the token economy in improving behaviors might be outweighed by the lack of autonomy of these patients. Remember, we are trying to prepare them for community care. We're trying to prepare them for living independently with their families or on their own in the community rather than in an institution. And if they're becoming dependent on rewards or if they're being told to act in particular ways, then it's not giving them the independence that they're going to need for life outside the hospital. So restricting the availability of pleasures, I think, is dangerous for patients that are already vulnerable. And if we're trying to prepare them for living independently, making them reliant on receiving rewards based on particular behaviors seems like it might be affecting their autonomy. The reason that token economies aren't used in the UK anymore is because there was legal action. Families of schizophrenic patients and other mentally ill patients sued hospitals for the discrimination that their loved ones were experiencing. Those who were most severe were getting the least number of rewards, and that was making their mental illness worse. So nowadays, we don't really use token economies. They've been replaced primarily by life and social skills training. This is learning specific activities, learning specific behavioral techniques that enable somebody with schizophrenia to learn about how to manage their disease and to live independently. And that allows them to function more effectively in the community. So token economies are more or less done away with entirely in the UK and replaced by social and life skills training instead.